It is just a huge honor for me today to be podcast interviewing Samuel E. Cress, D.D.S., the director of the Center for Craniofacial and Dental Sleep Medicine located in Sugar Land, Texas. He received his Bachelor of Arts Degree from Austin College in Sherman, Texas. He completed his Doctorate of Dental Surgery from the University of Texas Health Science San Antonio. Dr. Cress also completed his residency in Dental Sleep Medicine at Tufts University School of Dental Medicine in Boston and his residency in TMD through the American Academy of Craniofacial Pain. In addition to his practice specializing in dental sleep medicine, TMD, cosmetic, and full mouth rehabilitation, he is a clinical instructor where he teaches other dentists the benefits of airway conscious dentistry as well as diagnosis and treatment of patients suffering from TMD. He has successfully treated OSA, obstructive sleep apnea, and TMD patients since 2009. He is a featured speaker at industry conferences and educational seminars. He pursues ongoing advanced education in the field of dental sleep medicine, TMD, full mouth reconstruction, and currently holds a dual patent on an appliance for the treatment of OSA and TMD, recently granted FDA clearance. Dr. Cress has published several articles in the field of dental sleep medicine, has presented at the TMJ Bioengineering Conference in Barcelona, Spain. He's a member of the American Academy of Dental Sleep Medicine, American Academy of Craniofacial Pain, American and Texas Dental Association, the Academy of General Dentistry, and the Greater Houston Dental Society. He has been in private practice in Sugar Land, Texas for 23 years. His wife, Kimberly Cress, MD, is the director of TMS Serenity Center for Depression. They share their life with their son, Carter, currently attending New Hampshire School in New Hampshire. I had the honor to meet you. We were both American Sleep. We were both lecturing at the American Sleep and Breathing Academy conference right here in Scottsdale. I saw you, a couple of weeks ago?
A couple weeks ago.
And
yes.
And I got to run into another guy who's been on the show, David Gergen, with Gergen's Ortho Lab, who has come over to my house and done podcasts with NFL players sleeping with the NFL. David Gergen was the one who started convincing the NFL that you put all these money on these $1 million athletes and they're not sleeping at night. They're sitting there grinding their teeth at night. And he started doing NFL players. The next thing you know, he got the NFL to actually pay for it. Because, imagine if you paid $1 million a year for this great athlete, and he comes to work and he comes on game day and he's all tired because he's not even sleeping well.
Right, so he can't breathe.
So and everybody loved your lecture. Everybody was talking about you were the hit at the American Sleep and Breathing Academy. So in all honesty, in all fairness of disclosure, I graduated from dental school in '87, and they never mentioned sleep one time in my entire curriculum. When did this even become? When did this hit the dental schools? It wasn't there, but it wasn't there when I was there. When did sleep hit dental schools?
I'm not really sure about that answer because when I was in dental school, I don't even think that we even knew how to spell sleep. And it really wasn't until I actually got out and knew that it was kind of running around. And now, of course, it's the big buzz topic. And it's interesting. I spent some time talking to some new graduates who are getting out. And again, they have very little exposure to the sleep world or the TM world, which kind of surprises me because, again, when you look at dentistry and you look at comprehensive dentistry, that should be on the forefront. That should be the number one thing that we look at is how we exchange oxygen through our nasal and oral cavity.
Well, what do they say? You can go 3 months without food and maybe a week without water, but only 5 minutes without oxygen?
Something like that. We're all addicted to air, and so we kind of want it as much as we can possibly get it.
Yeah, so I just think it's absolutely interesting that you go into dentistry where everybody thinks it's root canals, fillings, and crowns, a broken tooth, a toothache, and what percent of your practice is sleep and TMD?
Well, it's interesting. Probably, I would say across the board for everyone's practice, it's probably right at 100%. But when you look at specifically treating those individuals, I'm going to say right now, currently, I'm at a good 40-45% treatment of patients with sleep apnea and TM over my practice. Now, it's not always been like that. It's been a transition over the past couple of years. But when you become more knowledgeable about the signs and symptoms of individuals who possibly are, suffer from obstructive sleep apnea, you then start looking at things a little differently. So your practice does take a dimensional turn, if you would, when you start integrating, you start becoming educated on what to look for patients with obstructive sleep apnea.
Your dental practice in Sugar Land, Texas is colonydental.com. Where's that name come from? Colony Dental.
So it's interesting. Sure, it's interesting. So Houston is obviously relatively large, 6 million people. And in the southwest corner of the city, outside the city limits of Houston, is an area called First Colony. It's or town called Sugar Land, or suburb of Sugar Land. And the actual development is called First Colony. And so when I was in dental school, I actually built my office building during my senior year in dental school. I don't know how many people would do that, and I wouldn't recommend it. But anyway, I was trying to come up with a name, and one of my friends that was in school, I said, we're living in First Colony. He instantly said, why don't you just name it Colony Dental Associates? So that's where that name originally came from.
Wow. So is Colony Dental.
And something more interesting is we're in Sugar Land, Texas. My office is on Sweetwater Boulevard, and my last name is Cress, like toothpaste, without a T, and I'm a dentist.
Wow. And cotton candy was invented by a dentist.
By a dentist, absolutely.
Wow. So the thing with podcasts is they're all young. I always tell people, send me an email, howard@dentaltown.com, and tell me who you are, where you live, all that. Man, a quarter of them are in dental school, and the rest are all under 30. You opened up with this big statement that, the sleep should be the first thing we dentists look at. And right. They're just like, man, I just paid $400,000 for dental school, and they didn't mention it. So back up that claim. What do you mean it's the first thing dentists should look at?
Well, when we look at dentistry, when I talk about dentistry, the actual restorative component of it, we notice that there are restorations that don't last a very long time. And a lot of that stuff happens to be with materials, et cetera, a way they were placed, that sort of thing. But if you step back and see what really takes the wear and tear, and why are we really tearing up our dentistry, the number of times that our teeth are together throughout the day is minimal. But at nighttime, that's where most of that destruction takes place. And so when you have a bridge, or you have a crown, or you have a filling, or a class 5, or whatever you want to look at, a veneer, pops off, et cetera, is it truly your technique? Is it truly the materials? Is it truly, the environment in which that restoration was placed? Or is it something more bigger than that, something beyond us? And what we have learned in the world of dentistry, in the world of sleep medicine, it's actually we're trying to protect our airway, and there, as a result, something's got to give. And so our dentistry and our teeth are the ones that take the brunt and the beating of it. And what I have learned, what's kind of interesting, what I've learned integrating dental sleep medicine to the practice is, yes, you can make a very good living at integrating that, but where you really perform the best is restoring these individuals who have torn their teeth up as a result of obstructive sleep apnea. Once you get the apnea under control and you start restoring these individuals back to the form and function in which they should have been, man, you see just nothing but just all you have to do is clean them. I mean, it really is. It's people who I have gone back and restored over the past, 10 years or so, we haven't done a dang thing on them with regards to dentistry.
So you think sleep is related to TMD?
Oh, well, we were taught in both the residencies programs that they are correlated. There's a strong correlation between the two. And if we can get the sleep under control and get the airway and passage, most of the time the TM issues kind of dissipate and go away. Now, there's other things that contribute to it, and I'm not here to debate that. What I'm saying is that there's a direct correlation between the two. And I see historically in my practice that once we get the airway under control and we get these people stabilized through different, phase 2 treatment, that yes, their TM subsides pretty quickly.
Okay, so I want you to again focus. My audience is still in dental kindergarten school, or they just graduated. So when they get out of school, before they can go do anything, they need to figure out, almost all the dentistry is on 4 6-year molars, and it's a filling or a crown, on a 6-year molar.
Right.
They're going to do 1-tooth dentistry for a couple years out of school. Is restorative dentistry related to airway health?
Again, from my practice and my experience, once I started integrating dental sleep medicine, the answer to the question is yes. I've done ad nauseum number of cases that are full mouth reconstruction, post-airway. management. And I tell you what, it really, you see things from a different light. And interesting comment you just made. You said most of your audience are young individuals who are just in dental school and really are just kind of getting, or kind of green to start out with. If they were taught, or if they would look at things through a different lens, not look for a single unit truth to be treated, but start in the very back of the throat and look at the airway, look at the soft tissues, look at the dentition, look at the things that have already destroyed. You look at the clinical signs that the individual actually presents, and you say, aha, there's something going on here that we need to look at a little bit closer. And what you will find is it primarily is sleep disorder issues that need to be addressed. And once those get addressed, then your restorative piece kicks in, and your restorations have some good life to them, some good longevity to them.
Now, I am one of the, I was born in 62, so of course I don't even have my tonsils and adenoids. A lot of these kids, when you said look back in the throat, a lot of times they're going to see these really huge swollen tonsils and adenoids.
Right.
Like say when I was a little kid, I think me and all 5 of my sisters had tonsils and adenoids taken out. Is that still
the only reason you did that is so you get the ice cream? That's the only reason you did it. Other than that,
actually, my mom, it's one of her most stressful stories. She always tells me. She said that they put me under, they did the tonsils and adenoids. She was in the room the whole time. She's all there, and then she had to go to the bathroom or something. But the 1 minute she left, that's when I woke up. And then when I walked in there, I was all crying and all upset and I told her that she left me, and she promised me that she wouldn't leave me, and she left me. She said she felt so horrible. But don't you think the tonsil and adenoid removal rate has really gone down in the last 50 years?
Well, it's interesting. It's kind of a great cycle. In fact, I parallel myself with an amazing ENT gentleman across the street. And you've got to, when you do dental sleep medicine, you've got to parallel yourself with MDs. You can't do it on your own for a vast number of reasons, primarily legally. But anyway, back to the comment or the question that you made, was the answer to the question was yes, that adenoids and tonsil removal when you and I were growing up, because you and I are just about a year apart from each other in age, that it was very common, something to do. Then insurance companies kicked in and then started limiting to that. And then ENT started following with regards to, well, I really don't want to go through that process of trying to get an adenoid and tonsil case approved for insurance purposes. So it kind of dissipated and went away. What's interesting is the ENT that I work with is also boarded in sleep and sees things from a totally different perspective. And so what he sees as his first line of treatment is removing adenoids and tonsils and opening up these kids' airways. And again, you see all the different issues associated with that. You see better grades in school, better behavior, less, ADHD issues, et cetera, by just giving these kids some oxygen exchange by removing the adenoids and tonsils. So I see the pendulum swinging back the other way, where now that we're becoming more airway conscious, not only on the dental side, but the medical side, that we are seeing ENTs, we are seeing that removal of adenoids and tonsils are more, thumbs up, a treatment option for sure.
There's, what do they call them? Trigger words, where you say certain words, it triggers them into some behavior. Right. Like I'm Irish, so if you say Jameson, I just run out of the room and go dive on the bottle. Myofunctional therapy is about as controversial term as you can get in dentistry. When someone says orthodontist, I mean, I've had orthodontists on this show that just dismiss the word myofunctional. They don't even want to have any part of it. Why is myofunctional therapy such a buzzword? First of all, explain what it is and what your views on it, and why is it such a trigger-happy word?
Sure. It's pretty interesting. I have an incredible team that's been with me my entire career. I just don't have a big turnover. And probably, I'm going to say 10 plus years ago, my lead hygienist and 2 other came to me and brought that buzzword, myofunctional therapy. And I'm sitting there thinking, please don't ask me to spell it, because I would definitely fail that one. But they said, this is something that we're interested in. Would you support it? And I'm like, absolutely. I mean, I'm all about education. I don't think there's a better place that you can invest your money and your time than in your own education. So I obviously stepped up to the plate, supported. I sent all 3 of them to New York with Barbara Green through her program, and then 2 of them took off, went back a second time for level 2, and then one, my lead hygienist, took off and went to level 3 out in LA. Coming back, guess who their first patient was me. And I think personally, it's kind of if you don't mind, Howard, I'd like to step aside and I'll come back to the myofunctional therapy, but What's interesting about me is the only thing I have not done to myself in the world of dentistry is dentures. And did I need any of that dental work done? The answer to the question is no. Jaw surgery, everything from full mouth reconstruction to implant to root canals, et cetera. The reason I bring that to the forefront is put myofunctional therapy back into it. Most of these orthodontists are these people who dismiss it or don't really understand it, have not gone through it. And if they would sit and go through them as a patient and understand the concept and see the benefits associated with it, then it wouldn't be a dismiss, if you would. So back to myofunctional therapy, we all learn to position our tongues in a certain way in order to speak, swallow, et cetera. So our tongues are very trainable muscles. And so what I have learned through the process and what I've seen in my clinical practice is that when you integrate myofunctional therapy, you train the tongue to position itself where it needs to be when you're finished talking, et cetera, et cetera. You become less weary. You're not quite as tired when it becomes talking or eating or chewing. The other thing that I personally think that every orthodontist should integrate is myofunctional therapy in all of their patients with regards to before they go into ortho. You see a decrease in relapse, et cetera, et cetera. So I'm really saddened when I hear that dentists, especially orthodontists, kind of dismiss it because, again, if they sat through it as patients and actually went through the treatment and went through the 14-week program, they would see the benefits and their attitude would totally change.
Now, you have two websites. For your patients, your office is Colony Dental. You talked about that. You also have another website, meridianpm.us. What right. is all that about?
So what's interesting about the Meridian, by the way, my website is samcress.com. Colony Dental was it, but it got moved over to samcress.com.
I know, but if you go to samcress.com, right. it goes right back to colonydental.com.
Right. So they crisscross, but both of those are my clinical one. And but the Meridian PM is kind of an interesting little story. So when I was fixing to actually exit dentistry and go find something to do because I was becoming a little bit bored and I guess the dentistry was becoming trite for me, and I got into dental sleep medicine, I noticed that one of the things that you really have to be conscious of when treating patients with OSA using oral appliance therapy is TM issues. If the patients have TM issues, you can exacerbate it, or if they don't, you can create them. So you have to keep in mind the complexity and the how sophisticated that joint is. So when I did the residency through the AACP, we had 7 different clinicians there who were educating, and they're all great. They're all I think they're all amazing. And you were to parallel yourself with one that you actually had like their philosophy, if you would. And through that whole process, I just figured that there would be an easier way to create an appliance where you could actually help patients with TM and pain issues. That being said, I got with a gentleman friend of mine by the name of Lamont Carpenter, and we created an appliance, or he helped me engineer an appliance for treating TM, and it's called, and we just named it the Meridian. And so I've gotten a tremendous amount of success with it. The interesting component is it's very non-conventional. It's an upper appliance. It's made in a specific bite pattern so that as we close our jaws are forced into a specific pattern. So because I did sleep, I went back to Lamont and I said, hey, is there any way we can create a bottom or orthotic, if you would, that would work in conjunction with the upper in order to create a sleep appliance? And lo and behold, we were able to. It's a dorsal design, which is pretty common. The number one problem with dorsal designs is the lateral fins will break off during bruxism, et cetera. And so he engineered a way of which that wouldn't happen. And so that's what created that whole patent component of it, is to how do we keep these dorsal wings from fracturing? Because the patients who actually have an oral appliance that's a dorsal design and they become lateral ruptures, you get failure of fatigue, they break, and you have to take them away. Those patients are really in distress for a period of time until they get their appliance back. And so that's what I was seeing in the sleeper world. And so when I came up with this Meridian for TM, we added the lower piece of it. Then we said, well, we'll just call it Meridian PM for nighttime, and it's been a hit. It's been very predictable, and its incorporation of the whole thing happened to be built around myofunctional therapy. So if we could keep the jaw, the theory behind the whole appliance itself, the Meridian PM, if we can keep the jaw in a comfortable position for the patient and train the tongue to stay forward, opening the airway, we've done the same thing that CPAPs do by blowing air and pushing the tongue forward, or any of the other oral appliance, whether it be a herps or any of those types of appliances, the taps, that brings the jaw forward, pulls the tongue forward, opens the airway. Why don't we just keep everything in comfortable position, compliance for patients, make them happy, don't put a lot of stress on the TM, and train that tongue to stay forward. So that's where that whole thing came into with regards to the Meridian and the Meridian PM.
That is that's pretty cool, because that site, instead of .com, it's .us. What is .us?
Well, because it's made in the U.S.
But is the U.S. is that the U.S. It's a country code for United States?
Yeah, U.S.
Okay.
So any you can have your own website .us. You could get that whatever you wanted to, provided it's available. But .us is in the same level as .com and .net.
So let's see yeah, that is so cool. Other than that, so when you go to Meridian PM .us, you have a picture of this. It says the Meridian PM treats primary snoring, OSA, and associated breathing symptoms. The Meridian PM stabilizes the lower jaw, maintaining a patent upper airway during sleep, decreasing the frequency and duration of apneic and hypopneic. Did I say that right? Apneic and hypopneic. Did I say that right?
Yes, you got it right.
Events including respiratory effort-related arousals, RERAS, such as snoring. The Meridian PM helps in oxygen exchange during sleep, as well as health and social consequences associated with snoring. Now, this is Dentistry Uncensored, so I always try to ask the tough questions. You say, and this controversial says, if left untreated, obstructive sleep apnea can result in a growing number of health problems, including high blood pressure, stroke, diabetes, depression, and heart attacks.
Right.
What would you say to a dentist says, oh, it does not? It's correlated. When every morning I make coffee and then the sun comes up, me making coffee did not cause the sun come up. Can you really link this to high blood pressure, stroke, diabetes, depression, and heart attacks?
Well, answer the question, me personally, can I link it? Just the research and the study, not only in the medical, but also in the dental world. The answer to the question is yes, because think about this for a second. If you're not getting the amount of oxygen, and our bodies are pretty sophisticated, well, they'll start shutting down parts of it in order to give areas of our other bodies that have or need the oxygen levels required. And as a result, our heart has to work a little bit harder in order to circulate that blood faster in order to get that oxygen exchange. So you're basically overworking the heart muscles. And so again, there's been ad nauseum amount of literature out there that supports the fact that individuals who have obstructive sleep apnea do have comorbidities, primarily cardiovascular disease. Regarding depression, or mental illness, if you would, depression more specifically, is that my wife is a psychiatrist, and so she treats patients with what they call TMS, transcranial magnetic stimulation.
You said that way too fast. TMS stands for what?
Transcranial magnetic stimulation, TMS. And so basically what that is, it's a dental chair with a magnet that comes over the frontal cortex of the brain, and the waves go through the frontal cortex, increasing the production of serotonin, which is missing in individuals who have depression, refractory depression, etc. So before she puts them in treatment, she always has sleep studies done to rule out obstructive sleep apnea, because they go hand in hand with regards to mental illness and depression. And so that's kind of what got me started on this whole arena with regards to that. So again, there's tons of medical literature, et cetera, that supports individuals who have obstructive sleep apnea also have comorbidities of depression as well.
Okay, well, I'm a little slow. TMS, transcranial magnetic
stimulation.
Well, you're that is amazing. And your wife is psychiatrist. You know what other dentist I know who's married to a psychiatrist? Some of the biggest legends in dentistry. Who do you know?
Mark Zuckerberg.
Mark Zuckerberg, whose son, Ed Zuckerberg, the dentist, his son Mark Zuckerberg started Facebook, but he is married to an MD psychiatrist. And T-Bone, Tarun Agarwal, who was did so much for Dental Town and started the Townie meeting and all that. His wife is a psychiatrist, and there's just a lot of dentists. And your wife is, she's I mean, her bio. I mean, she's an amazing person. She even completed a Harvard Medical School in this transcranial magnetic simulation. When I first read that, I thought, what is transcranial magnetic simulation? And she learned that from Harvard Medical School. That is.
She was originally one. Yeah, she was originally one of the pioneers about 16 plus years ago when it took off, and now she's part of Greenbrook TMS, just joined them, and as medical director of numerous clinics in the greater Houston area.
Wow. Does she, I've always asked when I'm having dinner with Ed and his wife's there, I always ask, you've been married to a dentist your whole life. Do you think dentists have this more? When I asked T-Bone's wife that, I said, do you think dentists have, they always say yes. Does your wife, I mean, she's married to a dentist, she runs her, do you think a lot of these dentists have depression, anxiety disorders, bipolar disorders, mood disorders, things like that? Do you think they're the same as the general public, or do you think they might have a little more propensity to it?
I think they're the same as the general public. I think that we may get the triggers or maybe exacerbated a little bit heavier just because our professions are so unique within themselves. Just the amount of everyday grind and pressures and the multitude of hats that we have to wear throughout the day creates and can express some of the issues that we currently have. I can't tell you, my wife's a little bit unique in the fact that we don't talk about our practices when we walk out the door. We're in the same building, and so we always kind of tease each other that we do mental and dental in the same building.
Mental and dental.
But when we walk out of the office to go home, we don't communicate with regards to practices and patients and so forth. So I really can't, and we really haven't had that discussion with regards to mental illness or depression or things like that in the dental world. Although I'll have to tell you a little funny story. When I got ready to start the practice, 27 years ago, you go into a bank and you're asking for loans, and they go, dentists have the highest suicide rate. And I said, I got that covered. I'm married to a psychiatrist, so we're good. But anyway, I thought that was kind of humorous. But that all being said, mental illness is kind of a unique entity within itself. But had it not been for her, and had it not been for her in the TMS world, more than likely, I wouldn't be sitting here talking to you because I was going to quit dentistry. I was burned out. I was tired. And she encouraged me to look at the world of dental sleep medicine. And I ran across Jameson Spencer, who saved my career. And he and I have been really good friends ever since.
Yeah, we had him on the show. He was an amazing guy. But obviously the men and women who serve, they have 26 suicides a day. So when dentists are saying we have the highest suicide rate, they need to call the United States Army. The United States Army has the highest suicide rate in the world. It's 26 people a day. But I always notice, even to this day, when you're working on a patient, I always know when they're feeling any discomfort or whatever, because I feel my own breathing change or my heart rate, or I start feeling tense. And 32 years, I trained myself, well, if you're feeling tight and all this stuff, that you're reading them. I think when they're laying there asleep, it's totally different. When they're feeling stress, they're making you and the dental assistant feel this stress and anxiety.
And I think that's what makes me kind of unique and special, is because I've sat in that chair and I've had all of those procedures done to me. And so the empathy level is pretty high with regards to that. So when a patient feels that way, it doesn't resonate to me because I can relate and I can pick up on those, signs, if you would, and help them walk through it because, like I said, I've been through it. So I kind of get that. At the same time, I really wish that more and more dentists would kind of follow my path, if you would, my lead, in order to put themselves in the same world. I've got a couple of dentists as patients, quite frankly, that I'm kind of surprised that, they're one of those individuals who don't walk the talk. When I was getting ready to do the TM appliance and making the Meridian PM, I have probably 20 plus appliances that are made for me. And I've slept with every one of them. I've had sleep studies done with every one of them so that I could create the Meridian PM, the things I like and don't like about appliances, bring them all together. The point I'm trying to make is I think that if dentists would go to the next level and integrate themselves into their practice the way that they should be, that you probably wouldn't see a lot of this stuff that's going on with regards to individuals, especially dentists who get burned out. I mean, we all get burned out in our jobs. I'm sure you do from time to time, but it's constantly reinventing yourself that makes things exciting. And I always look forward to the next day with regards to what will my practice bring to me.
Right. Gosh, I've had Ed Zuckerberg. I've had dinner with him and Karen, and his daughter Ariel, who my granddaughter thinks is the from the Little Mermaid movie or whatever. Come over the house, but hey, I told Karen Zuckerberg, and it's open to your wife, and it's open to T-Bone's wife. Like, wouldn't that be cool to get your wife, Karen Zuckerberg, and T-Bone's wife on? But if she ever wants to come on and talk about stress, because I've had all these practice management consultants on, and they'll all tell you, most of them off the record, that a lot of dentists who are having really big practice management problems, their own personal house isn't in order. And they're always saying, a lot of times we feel like we're armchair psychiatrists. And a lot of times you go in there, and if you listen to everyone in the staff, they're just like, no, the problem is Doc is batshit crazy. And so when they get these people to, like dentists are burned out. Well, burned out might be some form of depression. It might not be because it's a filling or a crown or a root canal or all the things you think it is. If your own brain isn't in order, it's really going to show up in everything you do in life. I mean, I tell people I'd rather have my foot amputated than my brain amputated. I'd rather have something go wrong with my finger than my cerebrum, And so it's really tough. But so they're young. They just got out of dental kindergarten. They want to learn more. Where do they learn it? I mean, there's the American Academy of Dental Sleep Medicine, AADSM.org. There's another one, the American Academy of Craniofacial Pain at AACFP.org. There's sleepapnea.org. There's ASBA.net. I mean, make it easier for her. She just got out of dental kindergarten. She believes what she says. What's the first stair up the stairway to get to where you're at the second floor? Decades later, where does she even start to learn this journey? Like your Meridian PM. If I'm on your website, and I am right now at meridianpm.us, how would I even learn the Meridian PM appliance? Where do I start?
Right. Well, actually, that's a great question. There's tons and tons of organizations out there teaching or trying to teach other doctors how to integrate or how to expose themselves. Put it this way, they're trying to expose dentists and new dentists in the area of sleep medicine. And I personally think what's interesting is the approach that I take it is very textbook. It's 1 + 1 is 2, 2 + 2 is 4. It's step by step by step. And unfortunately, I don't see a lot of organizations that do that. The Clinical Mastery Series does it, and it just if you could get your kindergartners, if you would, and I don't want to use that word. That's your word. I don't want to borrow that word from you. But anyway, the young dentists who are getting out of dental school, they're interested in integrating it or getting more exposure to it. I would look for a course that really taught 1 + 1 is 2, 2 + 2 is 4. Most of these organizations and meetings will go off on and have individual lectures that lecture a component of it, but really never puts it all together, never really connects the dots. I've attended a lot of CE and sleep, and again, that's kind of the ongoing path, if you would, or presentation, if you would, what I see across the board. That this one will talk about appliances, or this one will talk about screening, or this will talk about billing, or this will talk about some other component of it, and no one ever goes through and puts together a step-by-step process other than Clinical Masteries, which I think is an incredible organization. That all being said, if the individuals are really interested in it, I would probably start at a local level, if you would, maybe their local dental society, and take a course or two to see if that's something that they're interested in. I personally think that it should be kind of the forefront. Like I said earlier at this podcast, it should be the understanding that airway and airway conscious dentistry is where it's all begins. And if you get that part, a knowledge base of that part and understanding, when you get to the restorative phase, you will then start seeing how you can make these restorations in your dentistry last longer than they really should, primarily because you've gotten their breathing under control, you've gotten their TM issues out of under control, and basically giving these people a better life that they deserve. And of course, a lot of it does play a role in patient compliance and patient understanding and letting them understand the value and what it is that you do.
Well, you mentioned Clinical Mastery Series twice, and I have to hone in on that because that's right in my backyard. That's Pete Janicki and his amazing wife, Jen Janicki.
Jen.
Yeah, how's that? So talk about them again. I'm sure Pete wants me to have you talk about it for the rest of the show.
So, Clinical Master Series is an organization that I was blessed to run across about 1.5 to 2 years ago when I met Pete and Jen, and when I learned their direction and their philosophy and how they make better dentists better dentists by educating them and the level of education that they offer. I said, I got to be part of that group. I want to be part of that group. And so that being said, I was able to bring to the table, if you would, my area of expertise in the world of dental sleep medicine and the format in which we presented in. And they were very accepting and brought me on as one of the clinical instructors for that organization. And so that's what's really cool about it is they see the value in once you get the sleep under control, you better have in your toolbox all of the education possible for restorative, for cosmetics, for all of that, because those do go hand in hand. I've done numerous cases, where we've gotten individuals who've been diagnosed, we've restored them for full mouth recon, and we've gotten their index numbers and their sleep under control. Well, that's where your value, that's where your production, that's where your limits come into with regards to that. So I always tell docs, primarily seasoned docs, that if they're going to integrate dental sleep medicine to the practice, they better make an investment in their education with regards to restorative, because they don't want that restorative, A, to walk out the door, and B, they're going to do such a great service to the patients because they've already built such a, or sold such a value in what they do by getting these people breathing better, getting them sleeping better, getting them out of pain with regards to their joint. Now go ahead and stabilize them and restore them back to their proper form and function. So that's kind of where all of that blends in. And what's great about the CMS group is they do have a core of courses, from the occlusion courses to the full mouth courses to cosmetic, et cetera, that all fit the pattern of what we were just talking about.
So if someone wants to learn more at sleep, is your first go-to clinicalmastery.com?
I would say, I'm going to be a little biased here. I'd say yes, because that's who I lecture with. I'm a clinical instructor there. And so what we talk about is screening, diagnosing, et cetera, step 1, step 2, step 3, so that when you walk away from that 2-day course, there's absolutely no reason whatsoever you cannot integrate dental sleep medicine in your practice come Monday. But be prepared, because what you will see is you will then start looking at things differently and then have to restore these patients back. Where do you get the education to do that? Is going back to clinical masteries, learning, ultimate occlusion 1, 2, and 3, learning, full arch, full mouth reconstruction, those types of things, TM course, all of that are all integrated into the overall package, if you would, with regards to it. I'm not going to say I'm the feeder or the first, but I do believe that once you start looking at things through a different lens and you start looking again at the back of the throat, the airway, the symptoms, Mallampati scores, the tori, the exostoses, all of those types of things, you then start seeing things differently. And once you get them under control, patients, you build a great reputation with them. You sold the value of what you can bring to them from their overall health. When it comes to selling larger cases in order to restore them, it pretty much is a kind of a slam dunk, if you would. And I hand it all to the component of Jen and Pete pulling that together with regards to the Clinical Master Series.
I think Pete is an absolute genius. He basically built Dentaltown for me. I mean, when I started Dentaltown, he helped me for the first decade. And he is amazing.
Wait a minute, he's not that old. He's not that old. So
well, he did. He worked for me. He worked for Dentaltown for 10 years. And I mean, it's funny because when he left, he married Jen and started all that stuff. And it's just been amazing to watch. But still to this day, I mean, it's been years, we'll say, well, Pete always said, and I mean, I have so many Pete-isms that I still am always saying to myself, I'm so grateful to that guy. When you lecture for them, what are you lecturing on? Are you lecturing on the Meridian PM?
So no. What we do on the lecture, keep in mind, we're not trying to be self-serving or self-promoting. What we're trying to do is specifically teach individuals how to integrate sleep. So the course is divided into 2 days. The first day consists of basically the science of sleep, the screening, the testing. We talk about integrating with MDs and how to work all of that together. Then we actually run sleep tests with Itamar. Itamar is a phenomenal company that does the watch pads. So they participate with us.
Slow down, Specky. Itamar?
Itamar, Itimar, Itamar, the watch pad.
ITAM.
Itimar, Itamar.
Inamar sleep what?
They're called. Just type in watch pad. WTCHPAT.
Watch pad. Okay.
And then it'll come up. So they work with us. The docs that first night get to do a sleep study, home sleep study. The next day we go over, we would talk about in incorporating or interpreting sleep studies. The docs get to look at theirs, and then we talk about appliance selection. Which appliances do you use? Of course, we do mention the Meridian as a appliance option. And we talk about that. And then we also talk about, from that point moving forward, talk about case presentations, how you sell the cases, what happens when you have things that go great, and what happens when you have things that go wrong. So in my course, my lecture, I give the good, the bad, and the ugly, because you will be faced with one of those three on a daily basis. And so how do you handle that? And the other thing that's really cool about that organization, and more specifically, I'm going to say me, is that you kind of get me as a mentor, if you would. We love to mentor docs when they have cases, issues, that sort of thing. On my website, if you attend it, you actually get a passcode where you can go in and download all the forms. We don't want you reinventing the wheel. I mean, I can't treat every patient, but if I'm able to help you as a dentist treat and learn, screen, and treat patients with OSA, I personally feel that I've treated those patients as well. And so I don't want you to spend the time reinventing the wheel. I want you to spend the time learning about or screening patients and building a reputation, if you would, to become the sleep go-to doc with regards to sleep apnea. You may or may not know that the CPAPs are kind of losing their gold standard, if you would, in the world of sleep medicine. And so that being said, dentists really need to be on board, because the other alternative is, besides surgery, is oral appliance therapy. And dentists are the only ones who can make the oral appliances. So that being said, dentists really need to embrace dental sleep medicine, not only from the overall health or comprehensive dental perspective, but also from the perspective of they're the ones that are going to be the go-tos, if you would, when individuals either fail CPAP therapy or not even compliant with CPAPs.
So Itmar Medical, out of Israel, talks about a medical device startup providing simple solutions to diagnosing sleep apnea and heart conditions. Itmar Medical is a publicly traded medical device company that develops and markets innovative diagnostic therapy solutions. WatchPat, the company's FDA-approved flagship product, is used for diagnosing sleep apnea in the home environment. WatchPat is an easy-to-use, patient-led alternative. So you're big on that.
Right. There's several different home sleep studies. You know, Brayburn has one, Aries has one. There's several of them out there on the market. And I always recommend, even in my lectures, that the WatchPat may not be for you per se, but you need to have some type of component where you can follow up for titration and that sort of thing. And so the one that's been really successful for us has been the WatchPat, just because of the ease of use. Love the company. Joel Bliss, who is the rep, the dental rep, is amazing to work with. And so, he's been very supportive in these courses. And again, it's not about the product, whether it be the Meridian or the WatchPat or, any of the medical billing companies. It's about the patient, and you need some good armamentarium in your toolbox when you go after to help treat these patients. And so the focus is really on the course, is really on integrating it and what can you do to help your patients achieve a better lifestyle and better health.
Amazing. So on Dental Town, I've been a big fan of your posts. A lot of people, I'm sorry to ask this, it sounds so crude and rude and it shouldn't matter, but it absolutely matters huge. Is this insurance free? Do I have to learn medical insurance? Talk about insurance, because money is the question. What is the answer?
Right. I love that. The money is the question. What's the answer? That's pretty funny. So, it is the medical condition.
No, I'm sorry. Money is the answer. What's the question? So I know my homies. They're like, dude, I'm a Delta dental provider. Money's the answer. What's the question? Is this covered by insurance? Do you take insurance? Do you do medical insurance?
Right.
Talk about that.
Right. Right. So what's interesting is it is a medical condition, so it does fall underneath your medical insurance component of it. And it's kind of it's a lot simpler than I guess most people present. In the fact that's kind of a flow chart. And the flow chart is, first of all, do you have medical insurance? And if you do, you just need to prove a necessity. And so each insurance company usually falls underneath the same category as far as the check boxes of is it A, is it B, is it C, is it D? And if it's all those, then yes, we do provide benefits associated with it. You just need to know what the information is that they're requiring. And obviously, you want to produce the information correctly. That being said, you then look at the individuals. Do they have out-of-network benefits or in-network benefits, and which category do they fall? So once you go through this, I guess, a decision tree, if you would or if you wouldn't, and finally you get to the bottom line where there is medical insurance benefits available, then the individuals usually move forward with the treatment. And again, it does fall underneath the medical. Again, following the necessity, following the RX for oral appliance, et cetera. If you follow their rules and regulations and their step-by-step guidelines, more than likely you will get benefits. With regards to us, we do take insurance, but we don't take it as assignment. So we help individuals file for their insurance, and we do get some reimbursements back, and it's from anywhere from next to $10 all the way up to almost full fare. It's never consistent across the board at all. So it's kind of an interesting game. We have one individual in our office who does nothing but that on the medical side, not the dental side, but the medical side. And every day there's a new story. Every day there's an interesting category. Every day there's a new caveat that we have to dance around. So it's really interesting when you start integrating medical insurance into your practice. It is a different arena. And there are different companies out there. There's DS3, there's Dental Writer, there's all these other companies out there that can help you guide you through each and every one of those steps if you elect not to teach yourself. But yes, you want to make sure that you do get compensated for the treatment, and it does fall under medical.
Okay, I've had some sleep people on my podcast before, some of the ones you've mentioned, and some of the flack email I got and on the Dental Town was that when some people said that anybody who you're treating for TMD should be screened for OSA. And they said, if you got TMD, and then other people said, that's just crazy. But I'm going to tell you this Dentistry Uncensored, the brutal reality. When I'm in a bunch of dental offices or I'm talking to my friends, if they got any kind of grinding or whatever, all they do is see if their insurance covers a night guard. And then the assistant comes in, takes 2 Algid, set it, they make a night guard, and then 3 days later they'll deliver it, and maybe if you're lucky, they might slightly adjust it. But what percent of TMD do you think is treated like that in the United States today?
Oh, way too high.
But
way too
how high?
I'm going to go probably as high as 70-80%. I mean,
it's 90, dude. It's 90. It's 90%. Yeah. So talk to that guy right now. He's like, yeah, I treat TMD. If they're grinding or I see abfractions or teeth worn down, my assistant will go in there and he'll take an impression and make him a night guard, and we'll deliver within 2 or 3 days, and we're all done. That's 90% of what's going on. So talk to that guy right now. He's an old guy. Talk to that guy.
So let's pull up the part where you said the old guy. So how much of your continuing education component have you invested in? Is that something that you learned way back when to treat TM? Because how I was taught in TM in San Antonio is totally different from why I do it now. I believe it's your standard of care. I believe there should be follow-up. I believe that any individual who comes in with TM issues, you can do a quick screening on them to see what really going on. I then put the patient on a T-scan. I also do a CBCT. We get beam readers to look at the condylar elements of it. We really kind of hone in onto that whole component, if you would. And then we look at developing an orthotic that fits them specifically for what we're going to treat. In addition to that, we just don't give it to them and say, see ya. Our protocol in the office, we see you in 24 hours, we see you in 1 week, and then we see you in 4 weeks minimum, knowing that we're on call if something goes wrong or haywire, we want to hear about it, we want to go back. But interesting enough, before I do any of that, before I even commit them to an orthotic, I have a sleep study done. Since I've been doing this in almost 10 years, there's only been 2 patients who've had TM issues that we've done sleep studies that come back negative for OSA. What does that tell you? Tells you back to the question that you asked me earlier on the podcast, is there a correlation between the two? And the answer to the question is yes. We see it continuously. So that being said, I believe that the standard, it's just me, I believe this is the standard of care for individuals who have TM. You really should have a sleep screening done to see if it's OSA. If it is, you want to treat them appropriately with an orthotic for OSA, not an orthotic for TM. If it comes back negative, then obviously you want to treat them a little bit more conservatively with a TM orthotic. And I think it's all camps and philosophies, but when you integrate it and you do what I've done over the past 10 years, you kind of develop your own philosophy and you see what works. I'm like you, the 90%ers that do that, this is just me personally, I do not think that there is there's fairness to the patient in that type of treatment. That type of treatment modality. I think when it comes to TM, the integration with the patient and really learning the patient and follow them up with an orthotic to get them out of pain discomfort, whether it be a sleep orthotic or TM orthotic, to me is the standard of care. And I don't think personally that there should be any waivers or alternatives associated with that.
I love the way you just call it TM. Is that a thing? I mean, can you just call it temporomandibular TM without putting a D or a J?
I could put the D on the back of it if it makes you feel better.
But I mean, I've only ever heard that on this show from you, or you're the only one I've ever heard called it TM.
Really?
Yeah, but you know what? Because I have a problem with this. You know, if you say TMJ, the dentists get all mad. So that's just a darn. Well, I don't care what you think because all the patients call it TMJ. It's kind of like the endodontists don't want you to call it a root canal. They want you to call it endodontic therapy. I'm sorry, but I live in this little place called Earth, and nobody, they all call it a root canal. Same thing with the crown. I had an older dentist got mad at me because I called it a cap. And he goes, why would you say that? It's like, because I'm in Phoenix, and they come in and say, does that tooth going to need a cap? They don't say it's going to need a full coverage restoration, So I like TM because that solves the TMD versus the TMJ. Just call it TM. I like that. You're the first guy I've ever heard say that. But
oh my goodness, I can't. It's surprising. I'm just saying it's surprising.
So if you go on Dental Town, it's all organized by 50 message board forums, and the very last one is TMD occlusion, sleep apnea. And I'm looking at some of these posts, and one of the questions that was stated, it was some crazy guy named Sleep Doc. Oh my God, it was you. Says, for those of you that have integrated dental sleep medicine in your practice, what is the most common appliance that you prescribe and why? People are talking about the Herbst appliance, Somnomed Herbst. And so answer your own question. Another guy, Kent Smith, who you talked about, who is a past president of the American Sleep Breathing Academy, is talking about different deals. But I want you to answer your own question on Dental Town. For those of you that have integrated dental sleep medicine into your practice, what is the most common appliance that you prescribe and why?
The most common appliance that I prescribe is the dorsal fin, and more specifically, obviously, the Meridian. But the dorsal fin, because it gives you freedom of movement, the tap, all the other ones are Herbst. Those are more locked-in appliances. I also look at the dexterity of the patients. It's easier for them to get in and out. The only negative that I've seen in the past, not with the Meridian PM, but in the past, is the fracturing of the lateral wings there. But that being said, that to me is my appliance of choice, my go-to. Just like anything else, if you happen to be a runner, people like Asics tennis shoes, people like Nike tennis shoes, and so forth, you've got to find an appliance that you're comfortable with, and not one appliance works on every patient. And so you got to know your patients. You've got to know what you're treating, how you're treating it. Class 3, class 2. What's going on with the craniofacial features? Again, do they have TM issues, et cetera, et cetera. So I think the appliance selection is based upon those specifics. But once you find something that you like, something that works for you, stick with it. We as dentists love predictability, and we don't like surprises. And so if you happen to have some type of appliance that you use that, like for example, the Herbst or something of that nature that you use on a regular basis, and that's probably the direction I would go in. Dorsal has always worked well for me, and I think it's because that I was introduced to Dorsal when I did my residency at Tufts. And I think that's kind of where my spinoff or my affection or attraction to that appliance system or design kind of spun off, and I really liked it a lot.
Well, you're not going to believe I answered your own question on that. Did you know that?
I do believe I recall.
I just did it right now.
Oh, okay.
And guess what I answered it with? So I just answered your own question by I love on your website, themeridianpm.us. You have a PDF file, and it's a. Have you seen? You know what I'm talking about, right? That PDF file.
Yes. Uh-huh.
Yeah. So
Right.
I just answered your own question. I said this is what Samuel L. Cress. So I just uploaded your while we were talking Dental Town, but so more. I want to go back to more sleep questions. And a lot of people are still asking a lot about you talk about the Meridian PM. A lot of patients are on CPAP. What percent of patients do you think in America tried CPAP, don't like it, and would be more comfortable with an oral appliance? Versus what percent of CPAP people actually like it? In fact, one of the dentists on the thread says CPAP intolerance. What's the big deal? I love my CPAP, and then everybody starts talking about. Some people love it, some people don't like it. So where are you at on this? What percent of CPAP is happily ever after, and what percent they need to try something else?
I could be totally wrong, but I'd say a good 95+% is just. And of all the patients I've treated for sleep apnea, which has been hundreds and hundreds and hundreds, there's only been 2 that love their CPAP, and so I think
only 2.
Only 2 in my practice. But it's interesting is, CPAP, you can get some, you have compliance issues associated with it, but the efficacy is amazing. Oral appliance is a little bit on the converse side. You can get compliance, but you have to work at getting the efficacy. And the working part, from my perspective, standard of care is a follow-up and titrations. We don't let our patients out the door until we get them to right where they need to be. And then once we get them where they need to be, they're comfortable, the index numbers are comfortable, we're all satisfied and happy, then we push them off at 6 months and see them 6-month recall. Obviously, if they're dental patients of mine, they bring their appliance in when they get their recare. But if they're not, we call them back every 6 months just to see how things are going. So I do believe that if you're going to get into someone's health at that level, that you really, the standard of care the dentist needs to integrate into it. And you alluded to how these dentists make these TM appliances and just someone takes some impressions and send them on and maybe adjust them, bye-bye. To me, that is not, again, standard of care. And it's interesting, my really good friend Jameson Spencer has said to me numerous times that me as a clinician, I go way above and beyond treating patients with sleep and TM, and more so than anyone that he's aware of. And so I've heard that comment numerous times. But again, I think it's just personal preference, it's philosophies, and it's just the way you want to treat patients and the way that you want to be treated as a patient.
So we have 4. So let's see. We have 3 courses on sleep medicine. We're about to get the 4th one as soon as you make it. Are you gonna make us an online CE course?
Are you asking?
Yeah,
sure.
Absolutely. I think it's a big thing. We have one dental sleep medicine from getting started to billing. Another one, sleep principles of oral appliance. Well, we actually have 2 courses from Barry Glassman. That's really our only sleep guy, and then Mark Murphy. But I would love to have a course on there for you because again, they come out of school and they've spent $400,000 on student loans, and they really don't want to start dropping a ton of money. And so I did this with the Pain Institute. I said, you're showing them an ad to go to the Pain Institute. They're going to have to cancel a week. They're going to have to fly all the way down there. The tuition's expensive. That's a big jump to go from here's an ad, and now I'm canceling a week and flying to people's hand. So I convinced them to take each one of those weeks and condense each one down to an hour to deconstruct the bridge. So she's like, what is this Pinky Continuum 1? Then she can go to Dental Town, watch an hour on it. And then if she decides, that means a lot to me, I want to go spend a whole week. I wish, I think you should tell Jen Janicki, that's a tongue twister. I think you guys should do that with the your courses for what she's doing. What is the
occlusion courses and all the C courses?
I think it's kind of like this is what it reminds me of, because I took 100 hours of CE a year for 32 years. I got my mastership in the HD, all this stuff like that. And the biggest association, looking back 32 years of predictability, what separates a dentist who live happily ever after and achieve their goals and those that are burned out, fried, and miserable? I think the number one correlator is CE. The dentists that kept putting, and that's why I'm doing this damn podcast, is that you're commuting to work, hopefully, you put enough information in their minds, they start making right decisions, they get happy, they love dentistry, and it's all the things like that. But the biggest asset most people own is their house. Sitting there and doing a reverse mortgage. Instead of just dying and giving your house to your kids, you can sell off your house and they'll give you an annuity because the charts know how long you're going to live, especially with women. The average American woman lives almost so predictably about 9 to 11 months longer than her mother. Now, guys are all over the board because, they wreck cars.
We have all the bad habits.
Yeah, they have dangerous jobs. My sons, my two oldest sons are cell phone tower welders. They send me pictures 1,000 feet off the ground, and they love it because their number one sport was rock climbing. And then they found out that nobody will work on a cell phone tower because it's so frightening. But anyway, so how do they get you to do a reverse house? I mean, the 60-second commercial is not going to convince you to sell your damn house. Right. So the whole commercial is just to sell you to call them up so they can send you a CD and tell you, based on where your house is located, what it would be worth. You know what I mean? So they're just starting to start a conversation. I think those hour-long online CE courses are the best marketing for these institutes in the world because they deconstruct the marketing process into, I hear about it, I'll give it an hour, and then in that hour, you've got 1 hour to convince me I should come spend the weekend with you. So tell Jen and Pete that Howard's asking for a course from you online for that stuff because sleep. It's so it's so tough to go from 0 to 100 miles an hour. You know what I mean on this stuff.
Absolutely.
Yeah.
Absolutely.
So I want Dentistry Uncensored. I want to ask you another brutal hard question. Sleep got a very bad reputation right out of the gate in dentistry because everybody teaching you the course only had one incentive, and that was to sell you a $5,000 machine to go home and measure your patients. So the first thing I'm going to ask you is, are these courses about selling a machine? Do they need to buy some home sleep device? Do you agree with that was the beginning of dental sleep medicine and dentistry? All the conventions were selling you equipment?
Right. Right. I've heard that numerous times. And what I think is really great about, especially about clinical masteries, is it's not about selling anything. It's about educating. And I think that's where you need to find and align yourself with an organization that does nothing but educating. Although we do have, if you happen to want to go down that road, then we can definitely give you some experience based upon the professors or the educators' experience. But back to your question with regards to, do you need to buy all that? And the answer to the question is no. There are other organizations out there that can do HSTs, et cetera, where you can actually funnel all that out until you get your feet wet. I, on the other hand, was a little bit unique when I got out. I'm an all or nothing guy and always have been. And so I got into all of that to find out what it is that works best for me with regards to sleep. So, yes, you do need to be a little cautious when you sign up for different courses. What is their motive? What are they trying to sell? What are they trying to get into? Who's got what in? And that's what I think is kind of interesting. You had mentioned about the sleep course with the CM. Is it about Meridian? No, it's not. It's about integrating, and we only mention it once. And if you want to give it a try, go for it. If there's something else you'd like, we support that as well. And it's not about trying to commercialize or integrate anything into that component of it. And it saddens me when these docs walk away thinking they have to spend all this money in order to get into dental sleep medicine, and they don't have to spend anything. They just need to get educated. Let me back up. They need to invest in their education, but they don't have to buy any physical equipment in order to do that, to move forward.
Okay, we mentioned a lot about clinical sleep mastery because we're both in love with Pete Janecki, his wife Jen. I mean, it's a great team, and I mean, some of the people on that team are just unbelievable. But in all fairness, I want you to get a second recommendation. So if you had to pick between the American Academy Dental Sleep Medicine, AADSM.org, or the American Academy of Craniofacial, AACFP.org, or the American Sleep Apnea Association, sleepapnea.org, or the final, the ASBA.net. Of those four, who would be second to Clinical Sleep Mastery about joining that association to learn more?
Sure. That's a difficult question because they each have their own philosophies and their own way that they direct things. One that's more, I guess you have to kind of figure out where you belong in that arena. I've attended all of them, and I've got association affiliation with two of the four that you just mentioned there. And so that being said, it would really be tough. I think you have to understand what it is that you want out of an organization in order to become part of that organization. Does that organization feed you and support you in a manner which it makes you what you need to be, makes you a better clinician, and so forth? So that would be very difficult to say. I am a member of AACP and the AADSM, but attend them, find out what's going on, find out what philosophies and direction that you like, and if it fits your personality.
Okay, well, the correct answer was ASBA.net, because it's right here in Phoenix, Arizona. I don't even have to fly.
And that's where we met. That's
where we met. So I totally think the American Sleep and Breathing Academy is the best one, mainly because I can drive there in 10 minutes. So all those other ones that are in different cities, they should have been in Phoenix.
Well, those lectures at that meeting a couple of weeks ago, the lecturers were really good. In fact, you were one of them, but the lecturers were really a good selection across the board, and it was pretty awesome. I tell you, another group that I absolutely just recently just fell in love with is the DS3 group, the Dental Sleep Solution group, and so they're amazing too because they are non-agenda, they are non-political. And it's just an open forum where people can get together and exchange ideas. And I was just introduced to them in their meeting in Clearwater, Florida, this past February, and I've already signed up to attend again. And I've recently been asked to give a presentation there in their small forum. So that's a really good organization. The people I'm developing relationships and friends with in that group are pretty amazing, and they're all down to earth. They're all very neutral. So I would probably lean towards that one. Would probably be my second choice now that we've been exposed to all of those. That would probably be my second choice.
So you said the Dental Services Group, DSG?
No, DS3, the DS3, the number 3.
Oh,
Dental Sleep Solutions.
DS3.
Right.
Okay, DS3, Dental Sleep.
Guy Yaros and Jason Tierney and that group of guys and gals. Jody Jack, all of those people.
Is that Dental Sleep Solutions?
DS3, yeah, Dental Sleep Solutions. Mm-hmm.
Okay, let me see. DS3. I got DS3 Sleep.
Mm-hmm.
Is that them? Or what website did you say?
What? I'm sorry?
What website did you give for those? Was it DS3sleep.com?
It very well could be. I don't know what exactly their website is, but I just called them DS3s.
Okay, let me.
DS3 is actually the software of the organization that supports, and they're the ones that integrate the software into your practice.
So that is DS3sleep.com. Yeah, it's funny I don't know all their names, but Guy Yatros. He's been on the show, just a great guy. And who's that? Who's the smartest person in their whole group? The one from Phoenix.
Jason Tierney.
Yeah, I mean, that is a good group. Well, I can't believe we went over an hour by 10 minutes. One more controversial deal. The kids at a dental kindergarten school get confused because you can go to 100 different root canal lectures and no one talks about a camp. You know what I mean? You can go take every... I mean, I think the only controversy in pediatric dentistry is silver diamine fluoride. Otherwise, they agree a lot. But occlusion... You kind of got to decide, are you going to go CR or neuromuscular? Is sleep kind of like...
How about just skeletal?
Well, you're the man who said TM. That was new to me. So TM and skeletal. I like that. If someone asked you in occlusion, are you neuromuscular or CR? What would your answer be? That you're just...
Are those my only two choices? CR.
CR, but skeletal's better. But my question was, when I named those 4 associations, you said they all kind of do things differently, but you don't really see that in studying endo. I mean, you don't go to a root canal course. They say, well, the other endodontists, they're from a different camp. So is sleep like occlusion in that there's a bunch of different camps with a bunch of different philosophies?
I don't think there's camps. I think there's personalities. There's a little bit difference when you say camps. Camps are philosophies that they're teaching. These organizations have different personalities, and the personality, where do you play? Where do you find yourself at? And of those, of the ones that are out there, the ones that I just recently got exposed to, I think that one fits my personality a little bit better because I'm a little bit more of a free spirit. I got a big personality, and they're very open to new ideas and new concepts and integrating relationships amongst dental sleep docs. They're very big on that, and that really does resonate with me personally. So, again, I think it's more of a personality and what you're looking for versus a camp, if you would.
That's well put, because it's the same thing with sports. So many kids end up their favorite sport is just because they were exposed to all these different sports, but they really gelled with a specific coach. And like for me, and when I was in high school, the biggest personality in the whole school was the wrestling coach. And he was just like this vortex that sucked all these kids in, you know what I mean? And I saw that. I mean, so many people like Dickerson changed their life at LVI, or Dawson. I mean, I'd say a third of my dentist friends in Ahwatukee, Dawson, just changed their whole life. So that's probably well put. It's probably not the science, the math, the algebra, the calculus, but just the personality leading this organization and that fit for you.
Right, because you find someone you like, someone you then develop a respect for. My perfect example is Jameson Spencer. You develop a respect for him. You learning a lot for him, and they're always a go-to person that if you happen to have an issue where you need to bounce something off, that would be the first person that comes to my mind would be Jameson. And again, that's an example just because we met at the TDA. I sat in his lecture. I sat in his hands-on course that afternoon. And I instantly paralleled myself with him. And then obviously I've taken numerous courses with him. And actually it was kind of a little funny story. My very first lecture that I gave was a 3-day lecture, I'm sorry. And I extended an invitation to him. He showed up. And then he and I have lectured a couple times together. And so there's just a tremendous respect I have for him. And so as a result of that, I learn and I'm much more open to the communication and what can I learn from him and that sort of thing.
Well, I'm going to close with the first question I asked you. Is TMD and occlusion and sleep related? And what I think is very interesting on Dental Town is the same 2 guys, Mark Murphy and Barry Glassman, who did our sleep medicine online CE courses, also did our TMD courses. I think that is, and then of course, I think one of the greatest occlusion course ever is Michael Melker's, who did nuts and bolts occlusion. But tell all these guys you're mentioning, put an hour highlight show on the Dental Online CE, so these kids can find out if you're the coach for them, if your personality does it for them. I mean, I can vouch for you. I think you're a very charming, handsome, and intelligent man, and I really enjoyed. No, I'm serious. I think what you're doing is amazing. Big fan of you. Big fan of your course. Was there any question that you were wishing I asked that I wasn't smart enough to ask?
I don't think there's a question there, or I didn't go in with the mindset for a question and answer session. It's more of a chit chat back and forth, and I think you've done a fantastic job. And I really do enjoy, these podcasts that you do and so forth. So I don't think there's any specific question that you didn't ask or anything I specifically want to say. You were just trying to find out my ideas, my philosophy, my background, my journey with regards to the appliance system that I came up with. And so I think that's all been covered.
And was the FDA, when you got that clearance, were they just lovely to work with and you just recommend them to everyone? Or were they the proverbial huge pain in the ass?
You got to have 2 things. You got to have 2 things.
Money and money.
Patience.
Okay.
And patience.
I am not a fan of the FDA because I live in a house where a person had brain cancer and an American company made a medication, but it was under FDA approval and she couldn't get on the trial. So she had to sell her home to me and move to Scandinavia where she could get the prescription there. And I talked to John McCain about that when he was still alive, and I said, it's one thing for the FDA to say we don't approve this drug. We don't know enough about it yet. But dude, I'm dying of cancer. I'm on a different time schedule. I want this drug now, and I don't think you're a patriot. I don't think you're an American when you block an American research scientist from giving you a drug when your only alternative is death. And I told John McCain, I wish they'd still do it. You got all these Indian reservations that when you say, okay, we'll let them build casinos, they need to have an FDA-free zone. Right out here. I mean, you got Mayo Clinic, you got all these hospitals, and instead of this crap trying to get on some FDA trial or whatever, but I may be seeing you because you're on Interstate 59, which goes straight to four of my 5 grandchildren are in Beeville. So I'm always down there in Beeville.
Yes, right down the road.
How far are you from Beeville?
Probably about an hour and a half.
An hour? That's all that is right there, an hour and a half?
Yep.
Wow.
So please stop by. I invite you to stop by, and I'll take you to lunch or dinner, depending on what time you come through.
Wow. Well, if I got my grandkids, they only can eat chicken nuggets and French fries, so they're
I got a place for that.
You got a place for that. Hey, thank you so much for taking an hour out of your very busy day and sharing it with my homies.
You bet, and thank you so much for the opportunity and the invitation.